So at this particular point in time, we would like to introduce our guest speaker, and I will do that. So Isobel Mackenzie has over 20 years experience working with seniors in home care, licensed care, community services, and volunteer services. Isobel led BC's largest not-for-profit agency, serving over 6,000 seniors annually. In this work, Isobel led with the implementation of a new model of dementia care that has become a national best practice and led the first safety accreditation for home care workers, among many other accomplishments. Isobel has been widely recognized for her work and was named BC's CEO of the Year for the not-for-profit sector and nominated as a provincial health care hero. Prior to her appointment as a seniors advocate, Isobel served on a number of national and provincial boards and commissions, including the BC Medical Services Commission, the Canadian Home Care Association, BC Care Providers, BC Care Aid, and Community Health Worker Registry, and the Capital Regional District Housing Corporation. Isobel also served on the University of Victoria's Board of Governors. Isobel received both her undergraduate and graduate degrees from the University of Victoria and has a certificate in healthcare leadership from the University of Toronto. So obviously with that background, Isobel is very, very qualified for the position of seniors advocate. And I know that many of us have had the opportunity to listen to Isobel in previous years. I think that she probably rivals Dr. Bonnie Henry in terms of frequency of speaking opportunities. And so we really are fortunate today to have Isobel Mackenzie with us as a seniors advocate. So please welcome Isobel Mackenzie.
Thank you very much, Ken. And no, my colleague Bonnie, I can assure you, is much more overworked than I am over these past 18 months. But thank you for your kind words. And I was so hoping to be meeting you in person this morning. And I had hoped that I would be able to resume my getting out and meeting with people throughout British Columbia. It's been difficult. I was on the island, didn't leave the island for 18 months. I normally spend about 40% of my time out engaging directly with seniors in the province. But unfortunately, what we thought we were going to see in the fall of 2021 isn't quite what we're seeing. So I'm hopeful that we just have one more little bump or wave to get through, and that by the springtime, if not before, we'll be back engaging with each other with greater confidence. So, and I will look forward to your meeting next year in being there in person if you want me back. I'm just going to share my screen now, and I need the host to allow me to participate in screen sharing. Thanks, Jim. Okay. Let's get started here. All right, current status of BC seniors. So over the million mark, there are now just over 1 million people age 65 and older in BC. That's about 20% of the population, 1 out of 5. And as you know, and you've heard me speak of before, we're going to continue to grow both in terms of the absolute number of people over 65 and also as a proportion of the population. So over about the next 10 or 15 years, the proportion of people over 65 is going to go from about 1 out of 5 to 1 out of 4. So in about 2035 or so, we're going to see a quarter of BC's population 65 and over, and the entire population will grow as well. So the absolute number will increase as well. And as you know, I like to remind people that the proportion of seniors that we're going to see when we're at the peak is already being experienced in some parts of Canada. So if you go over to the Atlantic provinces, they have a higher proportion of seniors than we do. And if you look around the world at countries like Italy, Japan, and surprisingly some South American countries, you find that they already have a quarter of their population or more age 65 and older. So we can look around and learn lots from people who've experienced this demographic shift. Obviously, concerns about care and care costs is one issue, but the other issue is the labor market, that we have fewer active participants in the labor market. And we may be starting to experience that currently. If we look at where seniors in the province are living, over 90%, more than 9 out of 10 live completely independently. I tend to look at age 85 plus for a lot of reasons, which will become more apparent in a couple of slides. And even at age 85 and over, we still have more than 7 out of 10 seniors living independently. So the message there, in all probable terms, most of us will live out the entirety of our life in our own home. About 10% of people 85 and over live in what we would, a form of congregate living, sometimes called retirement home, assisted living, seniors independent living, but you've got your own unit, but you probably share a dining room and some activities, but you're still fairly independent. And then at age 85, we have about 15% of the population 85 plus lives in what we would call long-term care, nursing home, where people are not independent. Median income is 30,000, just under 30,000 a year. That's the lowest income of any age cohort past the age of 25. As you know, up until 25, many of us are in post-secondary education. We're training, but so by 25, we're sort of more large. So when you look at the income data, seniors have significantly lower incomes. And a good 30% of seniors in BC, almost a third, are fairly challenged economically. They're in receipt of the guaranteed income supplement, which is a pretty good proxy for poverty because it looks at your household income, whether you're all those kinds of things. So in practical terms, a person in receipt of GIS, which is almost a third of our seniors, their income is below 25,000, give or take, 26,000 a year, and their average income, I think, is around 22,000 a year. That's significantly less than a minimum wage job would provide for somebody. So we do have seniors out there for whom income sufficiency, having enough money, is a problem. And it's particularly acute, as you would appreciate, in the Lower Mainland, Southern Vancouver Island, where cost of living is significantly higher than some other parts of the province, although the Okanagan is getting quite expensive as well. We do see increasing participation in the labor force by people 65 and over, mostly concentrated, as you would expect, in the younger age group, 65 to 69. And I think we're going to see that continue to increase. It's increased continually since the time I've been here. And that only makes sense when we're living longer, we're living healthier as we live longer. And for the generations coming up, they entered the paid labor force later. So if you think about CPP, which requires, I think, something in the neighborhood of 44 years in the paid labor force to maximize your CPP, if you took time out to take post-secondary education, to travel, you're not going to get your 44 years in by the time you're 65. So I think we're going to continue to see that increase. Where are what type of housing are seniors living in? This is a bit interesting because even though people are living independently, it's only about half that are in single detached houses. This is a shift. Now, we're seeing another shift, which is people starting their housing in condominiums and townhouses, whereas 50 years ago you started with a house. But we are seeing that apartments, condominiums, the townhouses, duplexes, mobile homes, those are also a significant part of the housing stock for seniors, more so than the general population. So, about half are in single family houses, about a quarter are in a condo or an apartment, about a quarter are in a townhouse, a duplex, a mobile home, and then you've got the 6% that are in some form of either registered living, registered assisted living, non-registered assisted living, or long-term care. Take a look at the health data. I've started to talk about this a little bit because I think it is interesting to see that when you talk about seniors' health and you think about seniors as 65 plus, it's really a different story for people in the 65 to 84 age group versus people 85 plus. So if we take dementia, for example, you can see that under the age of 65, it is possible to develop dementia under the age of 65. It's highly improbable. It's fairly rare, but it does happen. So it's less than 1% of the population under 65 has a diagnosis of dementia. When we look at this population 65 plus, you can see 6% of the population 65 plus has a diagnosis of dementia. But if you look at this age group, which is the bulk of the population, 65 to 84, it's actually only 3%. It's really at 85 plus when you see that big jump to 20%. Now, the other way to look at it also is 80% of people 85 plus don't have a diagnosis of dementia. Now, it is, as you know, it's a neurological degenerative disease, and it is a disease where the probability of developing it does increase with age. That is true. But the sort of idea that you will develop it if you simply live long enough actually is not borne out by the data. Most people will live the entirety of their life without developing a diagnosed dementia. There's lots of cognitive aging issues that are not dementia. So also, when we look at high complexity chronic conditions, so again, under 65, it's only 1% of the population. And to put it in perspective, a high complexity chronic condition would be hypertension, high blood pressure, COPD, constructive pulmonary disease. It would be renal failure. It would be obviously dementia would be captured in that as well. So you can see that at 65 plus, 19% of the population has a high complexity chronic condition or conditions. But when you look at the age groups, you can see again in 65 to 84, which is the bulk of the population, it's 17%. So it's a little bit less, but that doubles when you look at the 85 plus. So really, you know, it's in our mid 80s and well into, and as we go into our 90s, when we really do start to see these health issues. And up until then, for the most part, most people are fairly healthy. And they're obviously independent and a whole variety of things. Frail in long-term care and end of life. Again, if you look at 65 plus, it's 4%, but it drops to 2% in this age group and goes up to 15% in this age group. So this is the frail in long-term care, not everybody in long-term care. Some people in long-term care are actually not considered frail. That's why this number includes a few more people than just long-term care beds. Okay, now I understand you wanted to hear a little bit about some recent actions and activities for seniors and what's been happening. So I thought I would just give you a snapshot of some of the things government's been doing, and I can talk about many of these have been things that have needed to be addressed, but because of COVID, it sort of amplified the issue. And also because of COVID, there was a tolerance, a willingness, I think might be a better word, to spend money on fixing some issues, and that appetite might have been more focused previously to COVID-19 on keeping deficits down and taxes low and so on and so forth. So the federal government has increased the OAS by 1.3%. Actually, that's just the standard increase. What that bullet should talk about, I'm sorry, is that starting next year, people over the age of 75 will see a 10% increase in their old age security. And those people received, I think, a $500 lump sum payment this year. So, and that falls on the heels of some increases to GIS that have happened. The province doubled the BC Senior Supplement. There was a lot of emergency relief to Senior Supplement. This is for low income, the lowest income seniors. So people on, we've got, to put it in perspective, we've got about 275,000 people on GIS, and about 65,000 of those receive the Senior Supplement. They're what I call the poorest of the poor. And it used to be, it was $49 a month for, I don't know, 30 years. And they've doubled it now to $99 a month. SAFER, which is the rent supplement, was expanded both in eligibility and the benefits increased in September of 2018. So you can earn a little bit more income and still qualify, and the ceiling caps were raised. And I apologize for that typo there. Fair Pharmacare, we made some adjustments to that for low-income residents around the co-payment and the deductible. So for people of medium and higher incomes, there's no practical impact, but for people on low incomes, the deductible they had to pay was reduced, and the co-payment was reduced. The government did expand adult day programs. Unfortunately, COVID hit shortly after the adult day programs were expanded. So we were just starting to see, we measured the improvement, the reduction in wait lists, et cetera. And then COVID hit, and basically they were effectively closed for a year. And I think it's going to take a little bit of time for those to rebound. There's been a tremendous increase in funding around long-term care in response to COVID-19, and some of that will have long-lasting positive impact and effect. And the government increased significantly the funding to the Better at Home program and expanded BC 211 to the entire province. So now wherever you live in BC, you can dial 211 and you can be connected. Activities that are still in progress. One of the issues I've been in discussion with government about, and I'm not the only one, affordable internet. And I think what happened with COVID is it amplified because seniors would be able to access internet at the library, at the local senior center, at the rec center, and those all closed. And so their ability to connect was eliminated. And I think that highlighted this issue. It's complicated. I personally think that one way to address it is through the CRTC, the Canadian Regulatory Telecommunications Commission. I think I've got that right. Where we went, as you know, a few years ago, we the CRTC said to the telecommunications companies, you must provide basic cable for $25 a month. I think we need something like that. I think we need basic internet needs to be available for affordable at an affordable price, because right now it is difficult to get basic cable for less than $60 a month. And usually you're bundling it with something and it's over $100 a month. And that's $1,200 a year. And when your income is $20,000 a year, that's fairly unaffordable. We still are working on home support. The co-payment needs to be addressed, as well as the delivery challenges. So that is a work in progress. Affordable transit, making Handy Dart affordable for low-income people. It's not an economic challenge for modest or even moderate income people, but for low-income people who use it frequently because you pay for each trip, it actually is, and it's not covered by the provincial bus pass. So there's work on that, as well as services in rural areas or around a whole spectrum. Those are all activities, I would say, that are still in progress. A couple of reports out of my office during COVID, and I'll give some highlights. We did a review of COVID-19 outbreaks in care homes that just came out a couple of weeks ago. And we did a report about a year ago, a little bit less, around the impact of visit restrictions in long-term care. So I'll just go over a little bit of that. So in the review of outbreaks in long-term care, we looked at wave 1 and wave 2. So from the beginning of the pandemic until the end of February, at which point pretty much everybody was vaccinated. During that period, we had 365 outbreaks at 210 sites. 72% of the outbreaks were considered contained. They had 4 or fewer cases, and the majority actually were only 1 case. And 75% of our outbreaks actually had no COVID-19 fatalities. But of those that did have fatalities, the fatality rate was 30%. So in practical terms, what that means is, if you look overall, 30% of people who contracted COVID-19 in long-term care died from COVID-19. That is a fairly high case fatality rate. It's higher than the flu. It's in the neighborhood of in long-term care fatality from pneumonia. Residents and staff, so residents who lived in long-term care, staff who worked in long-term care, were 3 times more likely to contract COVID than the general public. And residents were 32.6 or 33 times more likely to die from COVID than members of the population at large. So there really was a disproportionate burden of COVID-19 on long-term care. We found that there was a strong link between lower levels of registered nurse coverage and large outbreaks. That was something that I think we underappreciated, the impact of this erosion of registered nurse presence over the last 20 years in long-term care as we've shifted to licensed practical nurses and care aides. There was a fairly pronounced pattern that, and it makes sense when you think about it, that the higher skill level and training of registered nurses that become important in a time of crisis were lacking, and where they were lacking, the crisis expanded and the cases rose. Paid sick leave. So even though almost all care homes offer their regular staff some level of paid sick leave, the amount they offer varies from 2.5 days a year to 18 days a year. And we found a pronounced pattern between those care homes that had lower levels of, like fewer days of paid sick leave, to the greater likelihood of a large outbreak. And that also makes sense when you realize that in the review, 40% of staff reported coming to work when they weren't feeling well. We know that's how the virus was introduced. And one of the reasons why staff would go to work when they weren't feeling well is they wouldn't get paid if they didn't show up for their shift. And so while we usually look at paid sick leave as something, in my previous life, we wanted to control paid sick leave. You wanted to limit it. Everybody was fussing over misuse of paid sick leave. This pandemic hit, and it was a different issue. We need people to stay home if they are feeling the least under the weather, and our previous approach to paid sick leave frustrated our ability to achieve that. The testing, when there were outbreaks, we found was not uniform. And that continues to this day. We have taken, I would say, not just in this province, but Canada, within Canada overall, a very conservative approach to testing. We don't do mass testing, and we're still not doing it even with the availability of rapid antigen tests. And that, I think, is puzzling to some of us and continues to be puzzling to me. So we recommended, obviously, expanded paid sick leave, the staffing shortages so that there's people to substitute for the people when they call in sick, a decrease of contracting out for care services. We did find that there was a correlation there between contracting out and a higher case counts, increasing the prevalence of registered nurses, increasing the testing, eliminating shared rooms. We don't have many, 10% are shared, but they were 24% more likely to experience a large outbreak if there were shared rooms in that facility. And I think we can understand that. And booster shots for all residents. We are underway with our booster shots. We're going a little more slowly than I'd like. We started a little later than I'd like, but we have it underway, and we also need it in the community. And I believe we've made the public commitment. I'm hoping I'm not jumping the gun. I think the PHO has said that we will give booster shots to over 80s in the community, and I'm hoping people over 80 in the community are just approaching the 6 months from their second shot. People in long-term care, some of them are 8 months from their second shot, and they had the concentrated dosing interval, so their protection has waned significantly. And just to give you, this is an interesting graph. So what this is telling us is that our story of outbreaks, wave 2 was a completely different story than wave 1 in British Columbia. And also that whether or not we had outbreaks in long-term care really linked, until we see the vaccine, linked to our community spread. So what you're seeing, these two lines that you're seeing here, this blue line is the case count per 10,000 of population in BC. So this is how many cases of COVID for every 10,000 people we had. The gray line is how many cases of long-term care per cases of COVID, pardon me, per 1,000 beds. So when the pandemic started, you can see that, you know, actually we had a higher rate of COVID per 1,000 beds in long-term care than per 10,000 in population, but you can sort of see how they're linked, right? And then we start to see a crossover here, but you can see that the lines go up in tangent. So as the community cases increased, which is what you're seeing here, the cases in long-term care increased, right? So that's, and where you see this diverging point here, this is where the vaccine is starting to take effect. So here's when we started to roll the vaccine out, remembering that protection really kicked in 2 weeks past your second dose. So 6 weeks after basically your first shot, when we started this, you can start to see this divergent. Cases still continued to rise in the community. They stopped rising in long-term care because this is the power of the vaccine. So we know it's powerful. And this just numerically, and probably you want the slideshow, just shows you that you can see how the health authorities, this really was a lower mainland issue. Here's the cases per 100,000 population in Fraser, 2,400, coastal 1,500, versus over here on the island, less than 300, interior less than 1,000, Northern Health high, but that's because it's a small population, so the number's a bit distorted. And you saw that reflected in the outbreaks as well. The other report we did was on the impact of visit restrictions on long-term care. Some of you who, I'll put it succinctly, for a year, we heavily restricted the ability of residents to visit with their family members. And we took what was pre-pandemic visits that were daily or several times a week to visits that were once a week or less. We took visits that pre-pandemic were over an hour and sometimes several hours a day to visits that were less than an hour. Almost half of them were 30 minutes a week. And they visits where 2/3 of them were in common areas where staff were observing them, and where over 2/3 you were not able to touch your loved one. And remember, it was basically the same one person for a year. And so a number of effects, and I've written on that, and I would encourage you to read that report. But if you look at sort of what are some objective measures, here's the antipsychotic prescribing. So this is very troublesome. Here's where we were a year before. Here's where the pandemic hits. You can see that we were bouncing along. You know, we were going up a little bit. But then we had this dramatic up, a little bit of a dip, a little bit of up, a little bit dramatic up. Now, this is, as we started to lift visit restrictions, we've seen a downward trend, although it's leveling off. So we're not back to where we were, and even where we were was higher than it should be, higher than above the national. So we are really monitoring this and hoping that certainly by this time next year, we are at or below where we were the year before the pandemic. So that's sharing a little bit of the latest from my office. I'm going to stop the screen share now, and I am happy to take any questions. So I guess I turn it back to you, Ken.
Thank you very much, Isabel. That's wonderful information. And I really, as I was listening to you and looking at some of the charts, I was really wishing that I could convey the same information to some of these people that are currently opposing the vaccines and what have you, and causing some of the problems. But that's another topic. So if there are questions for Isabel, please raise your hand. I see Diane Wood has got her hand raised.
Ken, I'm a guest, but I want to say that, first of all, I hope that the slides will be shareable so that all of us will be able to take that information, which is so important to provide. One of the things that's been most disturbing most recently is what we're hearing from Alberta, and that is the issue of the triage that they have implemented as their way of proceeding on the effect in their ICUs. And of course, the more frail and affecting seniors, basically the percentages that they've allocated as to who will basically be not provided treatment if they reach a certain threshold. It's been very disturbing. I wonder if, Isabel, you have any information on this as to the implementation and what, if anything, BC has even looked at in comparison in that regard, but also what's happening in Alberta and probably in Saskatchewan because of their high escalation of outbreaks. That would be really important for us to know, because it's very concerning to many of our members how seniors could be treated in that situation. Thank you.
Yeah, and this applies to more than COVID. This is what we call triage in standard clinical terms, and it's a practice that has existed for over 100 years. And the principle of triage is when you have limited resources, you focus those resources on where they will do the most good. So, it started in the wartime, I think in World War I, where you would pick, this soldier is going to die regardless of what treatment we give. This soldier will recover, and you will choose to treat the one who will recover versus the one who, that's the basic principle. When this pandemic started, you have to remember what we didn't know, and we had these dramatic images coming out of Northern Italy and their hospital system. And there's a lot of ethical issues and a lot of burden on decision makers around this. So a decision tree was constructed for BC that never required implementation. So again, remember the basic premise is scarcity of resources. So you don't look at triaging when you aren't worried about running out of beds or ventilators or anything like that, right? If you need it, you get it. So we did have, and we still have, and I would think every province has, a system that says basically at the end of the day, here's the process you're going through to determine who gets that ventilator or who gets that ICU bed. So that exists. And it's not always age-based. It's based on who is most likely to benefit the most from it. So you could have a severely compromised 35-year-old with severe low lung function, who is not going to benefit, and you could have a robust 78-year-old, and the decision could be to put the 78-year-old on the ventilator, right? So it's not age-based. However, as we age, yes, when you look at who's, and then in public health, one of the more distressing decision points we can find ourselves at is when you have to get to years of life left, right? And that is that we never got to that. I don't believe we're going to get to that in BC. I don't think they're actually going to get to that in Alberta. As you know, it's about critical. We have, nobody's run out of ventilators. We have an excess of them, and that's really that's really the issue here. But I can appreciate however, what is happening is decisions to cancel surgeries. And they use the same principle in reverse, right? The most urgent surgeries go ahead. If it's a knee replacement, you've waited 8 months, you can wait 3 more. And that can have, some of those decisions actually have a more profound deleterious effect on seniors' mobility, right? So that the those subtleties sometimes get lost.
So thank you very much. I see a couple of other, Sarf, I see your hand is up.
Yes, thank you, Ken. Isobel, just a question. We recently had a federal election, and I know health is a provincial matter as far as delivery is concerned. I'm not too sure about the seniors issues, but how much it is provincial and how much is federal. But having said that, are there any things in the new, that we are expecting from the federal government, the new federal government after the elections, which we should look forward to as seniors or be concerned about?
Well, those of you who were born in 1946 or earlier can look forward to, and I think it might be 1947 by next year, can look forward to a 10% increase in your OAS. I think the federal government is looking at setting some standards for long-term care. It's problematic because healthcare, as you've pointed out, Sarf, is the responsibility of the provinces to deliver. I think what we have to be careful about is that a lot of attention has been focused on long-term care, and that is important. But we have to remember, that's why, context. Most people will never go to long-term care. And we need to be careful that we don't starve other parts of the system in order to feed long-term care. I think the most uncomfortable conversation that governments, both at all levels, are going to have with their citizens, who are the taxpayers, is the growing understanding of, if you want this, then we have to pay for it. Some of you've heard me say, everyone wants to go to heaven, no one wants to die. We all want great services, but lower taxes. You have to choose, right? There are some delicate conversations around what will be universal based on age, what will be income tested. People will have varying opinions around the fairness of the income testing, but I can tell you, and some of you on this Zoom call will have sat around decision-making tables where, you have this finite resource, you can give this much to everybody, or you can give this much to those who really need it, and expect those who can provide it for themselves to do so. I can say all this because my name isn't on a ballot. I continue to be surprised at our disconnect when it starts to be our tax, our actual money, without sort of being able to understand that that's the only place government gets money from. So I think that's what we need to be concerned about. We need to be concerned that we continue to recognize most seniors not only want to, but do and can age at home. They need supports. We need to make sure those supports are out there. And we need government to understand, this euphemistic language around, work smarter, not harder, do more with less, be efficient. All of those are what got us into the predicament we're in long-term care right now.
Grace, I see you got your hand up.
Yes, thank you. Isobel, regarding the antipsychotic uses in the facilities, are there any, are the facilities recognizing the need for more training for their staff so the antipsychotics will be decreased? I mean,
it's recognized that that is an effective tool, Grace, and it's recognized that that is something that should be achieved. There's not the rigor around requiring facilities to ensure that their staff have gone through the gentle persuasion course, or there's a few variations on the theme. That requirement is not there, and that's a good, these are ongoing discussions around what are we going to require care homes to do, and if we're going to require them to do it, how are we measuring that they've done it, and what's the penalty if they don't do it? So those are the parts I think that need a lot of work. I think there's certainly recognition of the importance of these training programs. I think the other complicating factor, there's going to be the COVID caveat or COVID mulligan out there for a while, that long-term care has been upended over the last 18 months. Notwithstanding that, there was staffing tensions or stresses, I think would be even before COVID, and how we're addressing that. And some of the things we want to do. I mean, if you increase paid sick time, you're doing it so that people who are feeling unwell can stay home when they're sick. You need staff to replace them, right? So it's not just the cost of they're paid when you've got to pay somebody to work their shift, and you've got to have that body to do it. And I do think all of the things we're doing now, if we keep moving forward with them, if we just keep doing what we're doing, 5 years from now, we will see a significant impact from it. You're not going to see it overnight, but you're going to look back and you're going to see staffing levels higher because we've raised the wages and we've attracted people to be care aides. We're going to see greater continuity because you're paid the same regardless of what facility you work at. So you no longer have an incentive to, hire on here as a new grad, and then as soon as the job over here comes up, you move. That is going to be gone. And I'm hoping greater accountability for care homes so that there is not going to be the incentive to short in some areas of care because they're not going to be able to benefit from the money they save from doing that. I think that 5 years from now, we can definitely be there.
Thank you.
Isabel, I see a question here from Tammy Welch, and it's on the chat line. It says, do you monitor privately run assisted living homes and condos, or just government run ones?
Funny you should mention that. So the short answer is the only monitoring we do of assisted living is we do report annually on out of the registrar for assisted living's office on number of complaints, et cetera. We have not monitored them the way we have long-term care. And actually, I have initiated a systemic review looking at the assisted living sector. And I'm looking forward to having the results of that review in the late spring, early summer. And the condos and independent living, there isn't a mechanism. If you're independent living, by definition, you're independent. We're not. We look at broader things. We monitor, utilization of the home care and those types of things, but we don't get into certainly people who live in condominiums. There is this gray space out there, and this is what I think will be highlighted in the assisted living review, is that a lot of people think assisted living covers buildings that are independent living, right? Because they look like assisted living. It's ironic. They say independent living, but they get their meals. And I think sort of understanding what the landscape looks like in BC, which this review will do, I think will be enlightening for a lot of people. And we may see some changes come from that.
I had concerns just because my mother lives in a building that is 2 wings are assisted living and 1 wing is privately owned condos. And all of the condos, they do their own meals and they do whatever they want. The assisted living sections use the dining room. But yeah, there just seems to be no place for them to go with their concerns. So I was just wondering if your office was a place to go for that.
They can come here, Tammy, but the regulatory ability, it is limiting, certainly for the condo owners. For the assisted living, absolutely, there's a registrar, you know, that's what we're going to be looking at. But the people, well, there's Consumer Protection BC, I guess. There's the Strata Property Act, and there's, you know, there's those mechanisms, and so we can help steer people in that direction.
Okay, thank you.
So Brian, did you have your hand up?
Yes, I did. My question is the broader context of the folks that are living in their own homes, et cetera, who are the majority, and I suspect will continue to be. And just, I guess, what do you see as the issues developing there? I mean, it seems that, I mean, there's a tax credit for, you know, putting in aids, et cetera. But most of the services that are provided are for profit, or many of them are for profit. And it seems that there hasn't really been a lot of serious thought about what the true social benefit is of having people stay in their house. And I'm wondering where that is on your radar.
It's pretty front and center on my radar, Brian, and it is, you know, there's the basket of people who are going to be able to figure everything out. They've got family members who understand how to work things through bureaucracy. They've got lots of money. They're not an issue, right? And part of the problem is, I think, from the government's perspective, a whole bunch of people are muddling through right now. And so why do we have to fix this problem? Now, one of the things I've drawn to the government's attention is this high number of people entering long-term care who had no home supports before they entered long-term care. In other words, they go from, you know, more than 60% of new admissions went from effectively no public support to total public support overnight. And that just doesn't happen in practical terms, right? So they're starting to, I think, understand, okay, we have an interest in making sure people get the support they need. Sometimes it's financial support that they need. The tax credits, they're nice. They don't fundamentally make it something that somebody can do if they otherwise couldn't do. You've got to, first of all, if you're low income, the tax credit's meaningless. You got to put the money out first, and you only get back 15% of what you spend in the tax credit, right? So it's nice, but it's not like shifting titanically or tectonically the outcome there. So it's, how do we make sure that people have the money if they don't to do this? And how do we make sure there's somebody there? Sorry, I'm just going to put this on message. How do we make sure there's someone there to coordinate it all for that? What I saw in my career in home and community care, I saw lots of families where all they needed was somebody to come in and just absolutely organize everything for them. That person could then leave and the family could take over, but the family wasn't capable of figuring out how to organize it all. And that's when they throw up their hands and say, it's long-term care. So, you know, lots of discussions in a very simplistic way. The approach would be, okay, Brian, we've assessed you. We've assessed that you qualify for this level of funding, right? That level of funding should equal pretty close what we would spend to support you in long-term care. So, you know, you're going to spend this much to be in long-term care. We're going to spend, we the taxpayers are going to spend this much for you to be in long-term care. When you add all that together, it comes up to about $8,000 a month. And for $8,000 a month, most people can figure out a way to make it work at home. But that's not the way we do it. And so the money piece is part of it. And then the other piece of it would be that a person would be assigned to them to make it work. Not our current system where the person assigned to them gives them all the referrals. Go call this person, go call this person, go call this person, go call this person. It overwhelms some people.
So Lawrence, did you have your hand up? Yes.
Yeah, thanks, Ken. Isabel, I don't have a question for you. I just have a pleasant task. I've heard you speak several times. It's just amazing your depth of knowledge and how you can put it out there so I can understand it. It's just, you're a rock star in my book. Anyway, if we were meeting face to face, I would give you this. But however, I'm not. So I think I'm going to jump
Okay.
in. I'm going to jump in my car and I'm going to come visit you probably sometime next week and leave it at your office for
Okay.
you to use as you so
Okay.
wish. Thank you
Okay.
very much.
All right. My pleasure. A pleasure to talk to you all. And I can't tell you how much I'm looking forward to meeting you all again in person. So when there's that opportunity, please let me know and I'll be there.
Thank you very much, Isobel. And I'm certain that we will take you up on that offer next year. We did have the opportunity to have you speak to us a couple of years ago, right after you became the seniors advocate. And the delegates were absolutely pleased, very pleasantly pleased with your presentation. And we look forward to having the opportunity to have you back again with a face-to-face information. So thank you very much on behalf of the BCGREA. And there was a question that I think Diana asked, was the presentation being recorded? And the answer, we asked Isobel if that was acceptable beforehand, and she acknowledged that yes, that was not a problem. So we are taking the opportunity to record the presentation today, and that presentation will be made available to all of the other members of our association that were not able to participate today in the AGM. So thank you very much again, Isobel. Thank you. As usual, you just absolutely amaze us with the amount of information that you convey to the public. And of course, that all applies to us as seniors. So thank you very much again.
Okay.
Thank you.
My pleasure. My pleasure. Thank you. Thank you, everybody.
Yeah. And we're going to take a short break now. Isobel, if you're interested in participating or continuing on, you're most welcome. But we will take a 10-minute break and then we will reconvene with the rest of the meeting. So time to go for a walk or run around the block or whatever you choose to do.